Thank you. And I want to switch over here to share my screen. Okay. Are you guys able to see everything?
Yep, looks good.
Okay. All right. So I have to apologize up front. I've been coughing a lot here recently, so if I need to stop for a second, I may do that as we go through the presentation. But thanks for joining us today for the CME. Please feel free to add any questions to the chat, and there'll be time at the end of the presentation for me to take any question or comments you have, and I encourage that, of course. So with the objectives today, I hope you come away with not necessarily an obligation to breach the subject of spiritual or religious beliefs in your care, but to feel comfortable if they come up in discussion, or if you identify this is a strength in your patient's care and use it in a strength-based approach to their treatment. I also want you to be able to feel comfortable in maintaining your own autonomy as a provider and not feel like you're sacrificing any of your beliefs or feel any sense or need to adopt those of your patients that you see. I hope I can show some of the benefits rather of using a strength-based model approaching patient care, and then of course help identify the role of religion and spiritual beliefs in patient care as well. So why this topic for CME? Primarily because it's not often discussed, and research indicates religion and spirituality is a part of a vast majority of people's lives. Daniel Hall, professor at the University of Pittsburgh, medical professor, who's also holds training as a minister as well, had mentions that doctors over the past few decades have been less squeamish about asking patients about their sex lives because they see really the information they gather to have medical value. So he encourages doctors to keep people's faith in mind as well, and reports that the practice of talking about faith with the patient is one of the last taboos there are. So there are correlations between patient religion and health outcomes, which can affect how you approach patient care, and it will be helpful to just look at a few things, and not just the problem and problem-based approach to treatment, but also again the strength-based approach. Obviously, it's imperative to get a accurate diagnosis and proceed with treatment, but then from there, not problems-based approach only. And I think at the core of a lot of mental health and medical professionals are really detectives wanting to kind of gain answers to problems that present themselves to us, and then help the patient or the client. And this topic, I think, lends towards solutions and strengths in the patient. So with the presentation today, I'll cover how patient outcomes are often tied to the religious or spiritual beliefs. So I want to talk first about the larger landscape within the U.S. in terms of religion. I know within each group there are different understandings or belief systems of God or higher power, but I want you to consider in the presentation today your own spirituality or religion as we go through, and how you can approach patient care with dissimilar or similar views.
I think she's special ed, right? And
So the Pew Research Center published a report in 2007 and in 2014 on the landscape of religion in the U.S. So I promise I will not cover all of these faith groups in the presentation, but while I will touch upon some examples of the larger faith groups in the U.S., and then of course more locally in Texas, and then in East Texas. So religion and spirituality in this presentation is meant to be broad in its definition. So the goal is really going to be to encourage you to engage the patient and understand them as an individual, since there are so many different theological and doctrinal differences even within the same faith. So the Pew Research primarily looked at the changing religious landscape, specifically when it comes to the decline of individuals identifying as Christian. Although a little over 70% of Americans still identify with this faith or religious group, and it tends to be the largest group. So as you see the comparison from 2007 to 2014 in the studies, in 2007, around 78% of Americans identified as being Christian. And then, of course, an 8% drop since then. And this has been pretty consistent over the past few decades with the decline. So in the study, Pew had identified Christian as, and of course in the red columns, that being consisting of Protestant, Catholic, Orthodox Christian, Mormon, Jehovah's Witness, and then other Christian, what's considered other Christian. And so if you consider the previous slide, you can see a lot of different groups that would fit in that category. So the deep blue color, bluish gray color on the far right in each of the years, the studies in each of the years represent Jewish, Muslim, Buddhist, and Hindu faiths and religions. And so these actually saw an increase over the same time period, either no change or an increase. And then you also see an increase in the third column there, the lighter blue. So the lighter blue tends to be what the Pew Research indicated as unaffiliated or atheistic, or none of the above. So when we talk about and look at the unaffiliated in this research, they noted that the unaffiliated are generally less religiously observant people who identify with a religion, but not all unaffiliated groups are non-believers. More specifically, many people who are in the unaffiliated category believe in God or a God and pray at least occasionally and think of themselves as spiritual people. So it's still, even though there are changes in the overall landscape, there are still significant amounts of people in the population that that are associated with the faith group or have a faith or spiritual belief. So the Pew Research also indicated minorities are also increasingly identifying with faith groups. And so I won't exhaust the slide here. You can see the numbers and the changes between 2007, 2014. So why is this important? Why am I showing you this information? We live in an area and state with a really diverse population, and that is increasingly becoming more and more the case, not just here in Texas, but around the world as people migrate, interstate migration, and then travel becomes really easier, especially in the last century. We're going to see more and more people that are not just fitting into one category as far as race or religion. So we're going to see a really diverse group. So it's really important to understand patients as they come in this way rather, to address any kind of spiritual or religious beliefs that they bring into the medical practice that may affect their care. So telemedicine has also made the world really a smaller place as well. And the patients we see or treat are going to be from a wide range of different ethnic, cultural, and then more specifically, as we talk today, religious backgrounds. So how does faith and religion affect health? So Dr. Rob Whiteley with the Department of Psychiatry at McGill University, and is also a research scientist, noted in an article in Psychology Today and referenced that a regular attendance to a place of worship really embeds individuals into a community of people that can offer support, specifically moral, emotional, social, all of which really encourages better mental health. And we know that, of course, in mental health, we want people to be more socially active, more engaged, and we definitely want to identify some of the strengths they have in that area and encourage that, especially in the treatment planning. He goes on to mention that the amassed research really suggests that the higher levels of religiosity are associated with lower rates of depression, anxiety, substance abuse, suicidal behavior. So it's definitely important as we, of course, see patients that come into the clinic or present to us that we're really aware of those things and, again, use them as a strength-based approach. He also mentions that religiosity is also associated with better physical health and subjective well-being. So when we look at, again, mental health, physical health, and where they overlap, again, being active, being social, being around your faith group, being involved in those groups would be really important. And then how you approach your care, how you view treatment, and their optimism or discouragement when it comes to outcomes in your treatment based on your faith belief. So it's important to understand these patients as they come in on an individual basis. So I really want to encourage you, as you see patients, to really ask some open-ended questions. Tell me about your faith. Does your worship, do you worship with other people? So part of how to initially get there is that I know in private practice in some clinics I worked in, obviously there's a thorough intake process, and a part of that process ask about faith and religion. So if someone responds and indicates some of that on their intake paperwork, that really opens the door. So I'm not really necessarily encouraging you as someone walks in your front door to start asking them about their faith. But if they open that door or if they indicate that on some initial assessment questions, ask them about it. Ask them how that's going to play a role, or if they want that to play a role in their treatment as they receive it from you. So again, patients are if they are vulnerable enough to open up and discuss this with you, it's not on the initial intake form, but they in the middle of an exam, they're diagnosed or have issues, and they discuss, their faith will get them through somehow, or they feel like they're being punished because of some things that maybe morally have happened in their life. That would be a great opportunity to step in and then ask more about their faith. So one of the ways this is beneficial is that my own experience in the community mental health is patients would often come in reporting significant life stressors, depression, or trauma, or all of the above. But then at the end of the discussion during the initial assessment or intake, they would say, when asked about the question of suicide or suicidal thoughts, they said that would never be an option for me. And so in exploring that, they felt like oftentimes if they committed suicide, they would go to hell in their faith belief. And so that would not be necessarily a free pass for me as a clinician to say, okay, we don't have to worry about suicide. It was a great opportunity for me to say, okay, let's talk about this more. Let's talk about how we can use this as a starting point as far as a strength in your treatment and how I can encourage that. And then we would often use it in follow-up appointments. I would go back on periodic appointments and say, hey, I know last time when you came in, you talked about your faith. Talk to me about, are you participating in a local group? Are you exploring opportunities with other people of the same faith? So encouraging that strength and building upon that. So more specific studies, including one from the AMA in 2016, looked at, it was a 20-year long study. So published in 2016, looked at 76,000 female nurses, most of whom were Protestant or Catholic. So by the end of the study, 13,000 of those nurses had passed away. So the study found that nurses who attended a religious service more than once a week turned out to be 33% less likely to be in the group that died. So compared to those who never attended. So the researchers noted that religion and spirituality may be an underappreciated resource that physicians could explore for their patients, as we have been talking about, as appropriate. So again, as the patient expresses that, or on the initial assessment, to bring that up. So going on in the study, the authors really are specifically say the doctor should not prescribe necessarily religious activities, but encourage it if it is something that the patient identifies. So the study noted other benefits, including that the women in the study who attended services were more likely to quit smoking, less likely to show signs of depression, even when researchers controlled for a long list of variables. So the variables that they considered were age, income, exercise, and non-religious social engagement. So friends, family. So the effects they found, the effects of religious attendance was stronger than any other form of participation in a social group like a book club or volunteer organization. So some pretty significant findings and recommendations from the AMA. And then a little bit older study that in my research, there's been subsequent studies that really reinforce this. So the Mayo Clinic study in 2001 noted that several other studies, even preceding that one, had shown that addressing spiritual needs of the patient may enhance recovery from illness, and that most studies have shown that religious involvement and spirituality are associated with better health outcomes. And then again, as we talk about mental health and physical health, the studies that they cited in the Mayo Clinic study in 2001 included better coping skills, less anxiety, depression, and suicide. So some real important statistics and information, again, to explore with your patient, and some statistics to back some of that need up. So the American Academy of Pediatrics 2007 did a study of pediatricians, obviously, in the Midwest. So at this point, I really want to encourage you to, again, as we talked about at the beginning of the presentation, to consider your own religious and spiritual beliefs as you approach patient care. So I want to exhaust the slide, but there's a significant number of pediatricians who either mentioned that their own spiritual and religious concerns were important in how they delivered the service of medical care, or they felt it was relevant in their practice. But barely half of them ever talk with the patient about their own, not the physician's own, but the family or patient's own spiritual or religious concerns. So again, really want to encourage you, if that window's open, to step through. If you're not comfortable, and I would definitely want to reiterate this, if you're not comfortable, I know that providers are consistently looking out for the benefit or beneficence of their patients. So looking at other resources to refer them to continue to encourage a strength-based approach. So a couple of case examples. I'm going to go a little broader here on the examples, kind of pulled from different research that I looked at. Other areas you may want to really consider are just different belief systems and how they affect health. So examples include some of the studies indicated patients reporting that God's punishing me, or I need prayer in my treatment. More specifically, there's a patient in one of the studies that indicated he was of a Hindu belief and faith, reported that his psoriasis was the result of him being punished. When confronted with the doctor asked, is this a part of you? Do you feel like this is a part of punishment from God? And he said, of course. It was not even a consideration for him. It was something that he believed as a punishment. And so looking at other faiths and considerations as how we can approach them, again, on a one-to-one basis. People within a Muslim faith, really, we need to consider the ability to approach them in terms of minimizing eye contact with female patients if you're a male doctor, for example, or if a family presents, oftentimes doctors will need to address the male, if it is a male and female that are visiting, really address the male in terms of questions about health in the patient visit. And so other considerations include Jehovah's Witnesses that may decline a blood transfusion. Jehovah's Witnesses believe that a blood transfusion, including whole blood, red blood cells, white cells, platelets, or plasma, are prohibited by their biblical faith, their belief. So one of the ways that I noticed in one of the studies indicated actually was related to organ donation. And so the individual that reported to be a Jehovah's Witness was engaged and talked to because the individual was on dialysis at the time. And so through exploring with the patient their religious beliefs, they were able to work with the patient on taking the donated organ and flushing it, somehow medically flushing it, so there was no blood or blood product in the organ as they transplanted it. Able to engage the patient in that way, and were able to help in terms of health. So I wanted to look at also more specifically children, and then how the role of the pediatrician can be affected. And so James Fowler, who has a doctorate in psychology and ministry, adopted stages of change from Piaget and Erickson and applied them to stages of faith, and then published Stages of Faith in the mid-1970s. So I want to discuss briefly these and include some possible impact on the pediatric practice. So this is a picture of my son Gabe. His name is Gabriel. We go by Gabe. And so for the purpose of this presentation, I did not take this picture for this presentation, but I felt like it really fit really well, and more specifically in Fowler stage. So universal faith, ages 0 to 2. Gabe just turned 2 not too long ago. So in our house, we talk about Jesus and pray. And he has often prompted us to pray preemptively at times. He'll say, Mama, Daddy, and then he'll show us his folded hands like he is in this picture. So Fowler notes that if a child perceives in this stage that God is special by a trustworthy adult, so the trustworthy adult being me and my wife in the situation, if the child perceives that God is special to us, it will also be special to Gabe. So there's some reverence that he will also imitate. Children that are in households where God's name is used as a cuss word or in anger, he says that they can develop a careless attitude towards God. So in this stage, more specifically, the children that look to adults, trustworthy adults, will not necessarily go by just what we say, but more or less action. So he's obviously mimicking some of the things that we do in our personal life. So the intuitive projective faith stage, so preschool years, during this stage, the child can project upon God the attributes of the parents. So for example, the parent is mad because the child's not eating vegetables, then God must be equally mad. If the parent says God is mad at the child for not eating vegetables, that just reinforces the emphasis on the belief for the child. Now, why would this be important in terms of pediatric care in your pediatric practice? If these things are internalized at this young of an age, and we'll look at other stages, it absolutely will affect mental health. It will affect the child's perception, self-worth, self-esteem. So in this stage, a different example would be if the parent tells the child that God loves them no matter what, when they do, regardless of what the child does, the child will be more likely to believe that God loves and forgives them. So a really impressionistic stage. The next one is the mythical literal faith stage. So early to mid elementary school. So in this stage, children really enjoy stories about mythical figures. Mythical figures that help mirror people, mirror mortals. So if you think about movies like Black Panther, The Avengers, Superman, Spider-Man, all of those things are mythical figures that help people on Earth, help mere mortals in their stories. So in terms of religion, they see God as not just a friend, but a very powerful friend who will answer their prayer for help. So the conflict comes when they pray not to be sick or sad and it still happens, or they pray for friends but are still alone. So again, some things to consider, especially if the family you're seeing has a strong faith background, to consider if you've already engaged or have engaged this family in regards to their faith, more of an understanding of this stage and how to address the patient and family. So the last stage he talks about are the preteen and early adolescent phases, so the synthetic conventional faith. Children in this stage start to attend services either in or outside their own faith. So they start to explore a little bit more and often describe themselves as atheistic or agnostic. But consistently, studies really indicate that most do report a specific faith in a religious system. So outwardly, they're saying, I don't believe, I'm agnostic, but the surveys really reflect something different in terms of actually there is some faith in a specific religion. So in this phase, questions may arise that continue on through adulthood. So some things that adults still really struggle with in their religious faith, things such as, why does a good God allow bad things to happen? Or why do people suffer? So examples of how this can affect the pediatrician again include if the patient presents in a depressed mood, there may be family conflicts where the patient may be seeking their own belief system or pushing back against religious ideology that they've been taught, or may start to question your own faith. They could present and ask. I know a lot of times in private practice, and this has happened in pediatric care with a friend of ours, is that the child will want to speak to either me alone or in the example that I know from a family that we're close to, is that they'll ask pediatricians or counselors questions like, why does God make people sick? Or why is God allowing me to be sick or without friends? So more existential kind of questions in relation to that. So being able to then engage the teenager, the child, and ask them about their faith and their understanding of God, and being able to engage them at that level will be really helpful. And again, if there's no comfort level at that point, then being able to, again, seek other options for them, either through their own religious or faith support system, or through counselors in the community that may be able to maybe specializing in that type of counseling. So I want to switch here to just autonomy for you, for the medical professional and the patient. So what if the patient you're seeing asked you to pray with them? So this may have happened to you already. It may not have happened to you. So the information in this section I really pulled from the AMA Journal of Ethics in considering how to respond to these different scenarios. So one of the things that they really encourage is taking a moment if the patient asks you to pray with them. And again, consider your own faith and beliefs, and consider your potential hesitations. So some examples of hesitation to pray could be, you don't want to upset the patient if they have different beliefs than you. The other could be that you're not accustomed to patients making religious requests, or in some situations, doctors may feel that, our medical providers may feel like this is a challenge to their ability or training as a doctor. A situation where a friend of mine that received a transplant and was asking the doctor to about the surgery, and the surgeon responded that when they're in the surgery room, they're in control. God has nothing to do with it. So obviously it was seen as a potential challenge in that situation to the medical professional. So some things to consider, and then asking, again, encouraging that dialogue between the patient and the physician a little bit more about their faith. So for physicians who are uncomfortable discussing their beliefs, and if the patient persists, you can just the article was really really outlined some specific things you could do. So you can let the patient know, I'm uncomfortable talking about my faith, but I will be with you while you pray. So another example of this is with a nephrologist of mine that had to deliver information, news to me about acute rejection, kidney failure, and so I asked to pray with them. So in my prayer, I was praying for his family and for him because they had to deliver really bad news. Oftentimes, not just to me, but several people. I knew he was of a Muslim faith, and so he handled it really well. And it wasn't something I was trying to project upon him. It's something I really felt compassion for him. So he just allowed me to pray, and then we finished at that point. And we have really good rapport, so that helps as well. So for physicians who are religious and comfortable talking about their beliefs, there's a couple of different scenarios. First, you need to assume that if you're spiritual, you may not share the same religion. For example, you may be Southern Baptist and the patient's Catholic, for example. So in this situation, you could just reaffirm to the patient, I hear this is really scary. I'm glad to silently pray with you, and then this really allows for the patient to know that you respect their wishes, but puts the responsibility back on the patient and lets them lead the intercessory prayer that they want to have. And then second, the article really touches upon is that you should assume if you have the same, again, religion, that you shouldn't be specific in your prayer. So if the patient is really pressing and wanting you to pray with them, at that point you should use a more non-denominational prayer, as that's probably the safest option. So, for example, asking God for support is safer than requesting specific outcomes. So instead of saying, let's pray for Jane to be healed of her appendicitis, you can say, pray for God to support her and give her comfort. So again, given the potential differences in beliefs regarding the faith of your patient and you, you want to keep it as brief as possible. Give the patient really room to express their beliefs, respect their wishes in terms of wanting to pray, but again, not sacrificing your own belief system or faith in the circumstance as well. So there's some extreme examples of where religious beliefs really go over the line. So obviously these are just a few headlines I pulled. I've seen some on TV where the parents really believe in faith healing to the point where they just abjectly, just neglect medical care for their child. Obviously, in situations where you feel like there's an indication of medical neglect, again, I know that this is something that you're all aware of, but obviously encouraging you within 48 hours to just at least report it. Don't try to investigate yourself. Just report it. Let CPS complete investigation. But there may be other concerns that are not necessarily hinged upon extreme religious beliefs. It could be some actual questions from some faith groups about vaccines, opposition based on their faith in regards to contents of the vaccine or how it is manufactured. And so again, I know I keep coming back to this like a broken record, but again, it's a great opportunity to try to understand the patient, where they're coming from, what their concerns are. So it may be more of an education about the vaccine. I know, obviously, with the COVID vaccine being out now, and I believe them really looking to develop it for smaller children, this could be, practical questions that may arise in your practice. So in implementing a strength-based approach, this was taken again from the American Academy of Pediatrics. So you really want to consider the patient's religious or spiritual beliefs, and it needs to include those. Again, as I mentioned earlier, a lot of times as we present on these topics, or as we look at diagnosis and medication, the focus is a lot of times on the problem instead of a strength-based solution. So moving from a solid diagnosis and needed medication possibly, and that needs to be a firm foundation without a doubt. But then pivoting from there to more of a strength-based model. And so the American Pediatrics really outlines this in their healthy active living for families, the implementation guide. And then more specifically, more practical examples of where looking at deficits versus assets in a family. And obviously, I want to really emphasize, because of the population numbers we looked at, the statistics we looked at, our religious or spiritual anchors or relationships or involvement, something we could build upon. So that could include, a child you're seeing in care, maybe going to vacation Bible school, and that may be something that's really encouraging to them during the summer. And so having them be socially active, out of the house, reducing social anxiety, being in a setting where that can be encouraged from your perspective would be extremely helpful for the patient. And then other situations where maybe the patient attends prayer at a local mosque with his family or participates in volunteer services with a local synagogue. So anything that you can identify that is going to be something you can grow from, help the patient in terms of encouraging the faith and religious beliefs as a strength. So during presentations, I always want to have some really practical examples when I watch. So I want to try to give some practical examples of how to implement some of these. So some of these may be really familiar to you as doctors. They're something new to me, so I wanted to share some of these, and one may not be as familiar. So the mnemonics, there's a couple of mnemonics that I wanted to share with you. This one is actually developed by Christina Puchalski. I hope I'm not butchering the name there. She's a doctor with George Washington Institute for Spirituality and Health. And so some brief questions you can ask during your assessment with the patient. So I know from working in a clinic, doctors can be scheduled, 4 20-minute visits in an hour. The reality is you're typically overwhelmed. And so we know, like for example, today's presentation is probably a very brief break in a very, very busy day. So I wanted to make these tools, if you are or not aware, something you can quickly ask in a short visit. So the other one, of course, the first one was FICA as mnemonic, and then HOPE as another example of a mnemonic, a brief assessment questionnaire you can ask the patient to engage them in their religious or spiritual beliefs. And then the last one is really taken from the local mental health authorities around the state use this in really determining not just levels of care, but also a treatment planning with kids. So the child and adolescent needs and strengths assessment, quite frequently just called CANS, really looks at different areas. So this is not something that I would necessarily encourage or ask you to go out and go purchase and look at. It is reliable, it is valid. It's free domain, it's open domain rather, but it's cost prohibitive in terms of the training part of it. So you have to really be trained on how to use this and implement this with people, with kids specifically. But I wanted to mention this as an example and then give you a more practical example on this part of the CANS assessment. So there is a strengths section on the CANS. So the questions on the CANS are weighted. So the reason for the weighted questions are if you have significant amount of strengths in cultural, spiritual, family involvement, then the level of care, level of intensive services is going to be less. So, so the more strengths, the less intensive service. So the fewer strengths, then the more intensive the services and more targeted the treatment planning can be as well. So again, just an example. I always encourage people, especially in clinical practice, just have a conversation with your patient. Again, if they're vulnerable enough to open up and discuss, and they're praying about this upcoming appointment, or they're praying about a medical procedure, or they're praying to get help, then if you're comfortable, really open that door. I think you'll find opportunity to really connect with the patient and improve the rapport. And so one of the last things I want to cover today is just self-care. So self-care is super important as you consider the trainings. These trainings that we're presenting, so in the last year, in relation to the pandemic, self-care is super important. I was talking to my nephrologist a few months ago, and he just confirmed what I already knew. Physicians are medical professionals are notoriously bad about self-care. So when I get a call about 8 o'clock at night about my lab work, I know the doctor is committed to patient care, and it is a wonderful thing, and it's to be commended. But self-care is super important. So he shared with me just things he did for spending time with his wife and two children. So it's imperative that you take time to consider your own religious and spiritual beliefs and strengths. And I encourage you to nurture those in and outside the office, wherever they may be, and also consider engaging, patients at your own comfort level and exploring the use of beliefs as a strength building approach to care. And then I also want you to consider CPAN as a support of that support that we provide to you. So when it comes to the mental health of children and teenagers in your care, we definitely want you to let us know how we can support you in that. And then we obviously receive calls quite often from doctors, and we're always encouraged when a doctor really calls and puts patient need out there, it really looks to collaborate and seeks help for them. So it's a really exciting thing for us to have an opportunity to do. So we really want to encourage that. If you're not enrolled, enroll with us. It takes a very short period of time, but if you are enrolled, please let us be a support to you. All right, and lastly, I'm gonna give you a better picture of my son. Since the other picture was him praying, so certainly enjoyed me and my wife. We're very blessed. And so with that, I want to open up to questions or comments about the presentation today. And thank you again.
Thank you, Wiley. So I had one question that really was specific. Let me get my screen to show us other. There we go. Had a question related to the research. So as far as it wasn't the Mayo Clinic, but the nursing research that you shared. Do you have that, or can you send that to me and I can forward that out?
Yes, absolutely. That's not a problem at all.
Okay, terrific. Other questions from our attendees? All right. I'm just going to real quick shamelessly plug CPAN. Again, if you are a PCP that works with children or adolescents, we encourage you to enroll with your local CPAN. You can contact the Child Psychiatry Access Network. The support is at no cost. It is fully funded by the state of Texas. State of Texas has realized our children and adolescents have the need for some serious mental health services, and of course, there's just not enough to go around. So when you contact your CPAN clinic, and you can see there the 888 number, you can then speak with one of the staff, and we can assist in getting you connected with a child psychiatrist to talk with as you're working through your care plan. We can also speak with you about finding resources or referrals, or even working with our therapists to create a plan for a child in the care that you have. We can even assist in looking for child psychiatrists if long-term therapy is needed by a psychiatrist, inpatient settings, and residential. So, and we are excited to be able to provide these services to you, the Northeast Texas area, but there are 12 hubs across the state. All 254 counties are covered with these CPAN services. And then finally, let me give you 1 second here, my last slide, and then talk a little bit about what we're going to be doing coming up. So hang on, where's my screen? I really am usually much better about this. There we go. So we have our next CME coming up on the 7th of July. Dr. Jamin Blood and Dr. Mary Baker will be presenting on behavioral management of ADHD. This has been a topic that we have a lot of questions for, so we're tackling this in a different direction. This time, we're continuing to provide continue to provide educational opportunities for children and adolescents, mental health. And then you can actually enroll by using this QR code here. Finally, let's get you up with this slide. So I want to thank you again for joining us today for our CME. We are excited to bring a wide variety of CMEs to our providers and their staff across the region and across the state. For your CME, please see the QR code on the screen. You may also contact our direct form by using this right here. And I will see if I can put that in the chat, unless Stephanie already did that. I know a lot of times she'll do that.
I haven't yet. I'm looking for it. I will do that right now.
Okay, super. So, any other questions? All righty. I'm going to stay on here, and Wiley will stay on for just a bit in case there is somebody who would like to ask a question with a smaller group. That's certainly fine. Thank you again for joining us. We appreciate your time. We know it's precious, and have a wonderful afternoon.